Welcome to the 15th installment of the COPSS-NISS series on the COVID-19 related data science webinars. COPSS is the Committee of Presidents of Statistical Societies and includes ASA, ENAR, IMS, SSC, and WENAR. I want to thank Professor Shihong Lin, Chair of the Organizing Committee, and all who helped organize this series of webinars. Thanks to Glenn Johnson at NISS and Lingxiao Xu, Associate Professor at Penn State and Associate Director at NISS, who provide technical and communication support for this series. This 15th webinar is scheduled at 4 p.m. rather than the typical noon time to accommodate our speaker, Professor Lydia Muraska, at Brisbane, Australia. So it's actually 6 o'clock in the morning in Brisbane. Participants will all be muted until the end of the presentation. So we encourage you to put any questions into the Q&A box at the bottom of your Zoom screen. Today's webinar was organized by Chris Barker. Chris has over 20 years experience in the pharmaceutical drug development with a unique background in the life cycle of clinical trials for drug development. He designed and analyzed the phase 2 and 3 trials, which led to the successful drug registration for the CellCept kidney transplant program. And he collaborates with drug discovery and development scientists, and also with medical affairs, commercial, and health economics experts. Chris is the 2022 chair-elect of the Statistical Consulting section of the American Statistical Association. He's an adjunct associate professor of biostatistics at the University of Illinois, Chicago School of Public Health, and president of Statistical Planning and Analysis Services Incorporated, which is his company at barkerstats.com. Chris will now give a brief introduction to our speaker, Professor Lydia Muraska from Queensland University of Technology, and I turn it to him, and then because it's 6 o'clock in the morning, I will show a pre-recorded presentation of the talk, and then Lydia will be on the call to answer any questions. Chris, over to you.
Thank you very much. You can hear me, right?
Yep. Great.
So Dr. Muraska is the director of the International Laboratory for Air Quality and Health and distinguished professor at Queensland University in Australia. She is also a consultant to the WHO. My background is public health, and with the pandemic, Dr. Muraska sort of first came to my attention because of an open letter that she and I think 249 other aerosol scientists wrote to the WHO about aerosols. That open letter is online, you can find it. The WHO has since changed its policy about aerosols and airborne transmission. The CDC has changed its policies. A key issue is that the virus could be transmitted airborne or aerosol 60 feet or further, not just the 6 feet. So she's going to speak to that. Just a little thumbnail. There's a lot of math there. I don't know how much she's going to show. A lot of physics that goes into the aerosol transmission. I've no doubt it's going to be a fascinating presentation. So I will leave it at that, and she let her video run here.
Good morning, colleagues from sunny Brisbane, and many thanks for inviting me to give this presentation. During the presentation, I'll be talking about not just COVID-19, but other respiratory infections. And in the lead to the presentation, Chris Barker and Jim Rosenberger and I had a number of conversations of what would be of interest to you to include in the presentation, which I tried to do. If, however, there's something which is not in the presentation and you are interested in, we can, of course, cover this in the question session. So in the presentation, I'll be talking about a few general points. Introduction, airborne transmission, to put things in perspective, generation of particles during respiratory activities, characteristics of the particles, dynamics of particles in the air, evidence from the outbreaks and modeling, and finally, mitigation beyond COVID-19. It would be an underestimation or understatement to say that the world was not prepared for this pandemic, from whichever angle we look at this. But of course, this wasn't the first epidemic or pandemic in the living memory, and I'm just talking about the pandemics or epidemics of respiratory infections. So there was the Spanish flu, of which we've heard a lot. Please note people wearing masks here, and there was SARS in 2003, SARS-1. Perhaps just an epidemic which didn't make sufficient impression of the world. So what lessons have we learned and why were we so unprepared? And again, I'm just focusing on the airborne transmission on this angle of the pandemic. So there was the confusion. The first point, you may remember in March last year when the Director General of the WHO tweeted that COVID-19 is not airborne. Well, of course, it is airborne, and it's something which we knew for a long time. It is airborne like other respiratory infections, and that's what we've been trying to persuade the world to consider over the past over a year. Then there was another aspect of confusion, the masks. So first, there is a statement that there was no need for the masks from the WHO, but then the masks became mandatory. So this confusion certainly didn't help anything or anybody. Even bigger confusion perhaps was in relation to definitions. Is it aerosol or droplet? In aerosol science, where I belong, aerosol is an assembly of liquid or solid particles suspended in a gaseous medium long enough to enable observation and measurement. But droplet is a liquid particle. So it has to do with the composition, but not with size, which is, as I learned during the pandemic, very different in medical sciences. Aerosol are smaller particles, droplet, larger particles, with a boundary put around 5 micrometers. Well, nature or physics doesn't obey such sharp boundaries. Now, don't worry about these differences, and I will call them, these objects, particles. It's a neutral term and hopefully avoids these problems with the definitions. Another problem regarding definitions was short or close and long range. What is short? What is long range? So is it 1 meter? Is it 1.5 meter? Expecting again this sharp division, or 1 kangaroo apart. You can see this in Australia. There are signs in many places, 1 kangaroo apart, which is about 1.5 meter. Well, again, there is no division. It is a continuum. And closer to a source, to any source, in this case, an infected person, concentrations are higher, which means that shorter exposure time may lead to infection. Away from the source, concentration are lower, longer exposure time are necessary for infections. So all these confusions obviously didn't help in understanding what is airborne transmission and in turn what to do about this. So basically, airborne transmission is inhalation of virus-laden particles anywhere in the room. Like in this image, we've got an infected person, we've got susceptible people away from the infected person. There was a tendency to call airborne what's past that distance of 1.5 meter or whatever, but really airborne transmission is inhalation of the virus anywhere in the room, close or further away from the person. So with this general understanding, let's talk a little bit about particle aerosolation. In principle, we can say that the process of particle aerosolation results from the passage of an airstream at a sufficiently high speed over the surface of a liquid. Now, which is that stream and which is the liquid? Here we are talking a passage of air through our respiratory tract, and liquid is what's lining the different parts of the respiratory tract. In principle, we can compare this process to a relatively simple process like in this old-fashioned perfume bottle or a nebulizer. The point, however, is that, as you can see, our respiratory tract is much more complex than any of these two items. So it is like a number of nebulizers were operating in our respiratory tract. So the way it works, and again, from very big simplification, multiple process of particle aerosolation. If we start from the bottom of the respiratory tract, the process there is that fluid blockages form during exhalation in this bronchiole region, and then they burst during subsequent inhalation, and that's how the particles are produced. A slightly different process occurs in the larynx area, and here it's aerosolation during voicing due to vocal cord vibrations. And yet again, a slightly different process in the mouth when saliva is aerosolized during speech articulation. So this is part of the complexity, but not the end of the complexity in the respiratory tract. So after formation, these particles, before they are emitted from the mouth or nose, undergo various processes, in particular deposition, which changes the original size distribution, or even more complex processes like described in the science paper last year on surface deformation and what happens then. We've tried some years ago, we've tried to, in a qualitative way, to discuss this, just that first part of the process. So what happens, how it goes. So airflow is this bronchiole region. So airflow goes in this way. And as you can see, the bronchiole contracts. And then eventually when the air goes the other way, it bursts, and that's how the particles are formed. But the reality is that we cannot measure this process directly because there's no instrumentation which we could put there. So therefore, the only way we can understand or explain what's happening there is to model these processes. Well, despite these problems, we have reasonably good understanding of the characteristics of the particles once they are exhaled from the mouth or the nose. So this is how size distribution of particles from speech and breathing looks like. So this is number size distribution. So first of all, you can see that the size distribution spans a size range of several orders of magnitude. The majority of the particles are small, and you can see that this is vertical scale is logarithmic. Therefore, this clearly the majority is here in this smaller size range. The importance of this is that they suspended in the air for a longer period of time. Now, this first mode here, or peak here, is due as a result of a fluid film burst, as I explained, and from the deeper parts of the respiratory tract, and these particles are smaller. It is thought that this is how H5N1 is generated because that's where the virus resides. The slightly bigger peak is laryngeal vibration mode, and this particle span also a larger size range. And finally, the big one, oral speech articulation. This is thought to be the source of H1N1. So it does matter, of course, where the virus is located. This may appear very simple size distribution, but this is not something which comes from an instrument. There are a number of instruments required to measure this, and then about 10 data processing steps to derive to this distribution. Now, please notice here that we are talking about, in the scale, we are talking about number size distribution. Likewise, we know quite a lot about concentration or emission rates of particles from respiratory activities. So this is from the same study from which the size distribution came. And what you can see here, that there are several different activities. So breathing, nose, mouth, singing or coughing, or that R is the closest to singing. So what you can see is that the smallest concentrations are as a result of breathing, whether nose or mouth, higher voicing, counting, but the highest by far are from singing. Very similar conclusions was derived by Asadi and colleagues, where here they compared different respiratory activities and breathing and speech, and show the increase with the loudness and the voice compared to breathing. So in summary, we have a quite good understanding of particles generated from respiratory activities. So in terms of the size, the majority of these particles are smaller than 1 micrometer, and the vast majority are smaller than 10 micrometer. These particles are light, and therefore they can stay suspended in the air for a long time. And importantly, all respiratory activities, including breathing, generate particles, but vocalization leads to higher emissions. Now we can ask, okay, where is the virus in these particles? Often an expectation is that we are talking about a naked virus. SARS-CoV-2 naked virus is of this size, about 0.12 micrometer. But the reality is that the virus is never naked in the air, because it is generated in these particles, water-based particles, which means there's also water, there's mucus, salts, and so on, which means that ultimately the particle carrying the virus is bigger or much bigger than the naked virus. It's been shown that in relation to this virus, SARS-CoV-2, particles smaller than 1 micrometer contain higher loads of the virus. So what we can summarize, the majority of the particles are in mid-submicrometer range and larger. Now, something important to note, this is the paper which I referenced in the previous slide. This is the size distribution obtained by the researchers conducting this study. So first of all, they used a similar instrumentation as we used in the study, which I've quoted a moment ago, but they've also used this sampler to sample for the virus in 3 stages. It cannot be higher resolution, or would be difficult for this. Again, here they were all respiratory activities considered in background, because it was not a laboratory study, it was in a hospital environment. And again, several data processing steps were required. Something which I'd like to draw your attention to is the scale here, because you may ask why in this case the peak of larger sizes is much bigger, because here we are talking about mass distribution. Mass, which is obviously related to volume, means that the small number of larger particles contributes much more to volume, because of this is R diameter square or radius square. So this is important. Well, and as I said, the highest viral load was in the smallest particles. So summary about virus-laden particles, what we know about this. Overall, smaller particles contain higher loads of SARS-CoV-2. This may be different for different viruses. Smaller particles come from deeper parts of the respiratory tract. That's where the virus is located. To the contrary, larger particles, less virus, they originate in the mouth. And again, breathing, speaking, the main source of these particles. All right, so now what happens with these particles in the air, the dynamics of the particles in the air? The first question which usually comes is, do they evaporate, or what happens as a result of evaporation? They contain water. Some years ago, I did this little simulation of evaporation time of water particles of the diameter of 1, 10, and 100 micrometers under different conditions of relative humidity. They also, the last line was particles containing sodium chloride solution of this particular concentration, because this relates to the concentration in our respiratory liquids. So what we can see here, that particles of 1 or 10 micrometers, which are of our main interest, they evaporate within a fraction of a second. A very, very small fraction of a second. So really, this is an extremely fast process. And basically what we measure is usually already evaporated to the stable diameter. Now, as I mentioned, composition of respiratory particles is much more complex than water. And therefore, this whole process is more complex than just for water or salt solutions. But nevertheless, it's been shown that evaporation brings the particle ultimately to the size of 20 to 40% of the initial size. It's usually not completely dry, some water is left. But regardless, it is very, very fast process. So basically what we measure is usually already what's called a droplet nuclei. I left the term because that's how it's been used. Now, another question is what happens to them in the air, and it's often referred that they are falling in the air. But the reality is that they are floating in the air. And here are some numbers from an original Wells paper. Wells, the kind of father of this science. And if we look at what happens to particles of our diameter of interest, 10 or 1, the falling time or time they spend in the air, and this is in still air, is very long. So for 1 micrometer particles, 30,000 seconds. So basically they stay in the air. Now, how do they travel in the air? I like this image from this paper showing the particles that originate from the mouth or nose. So, well, there's that small number of them indeed fall, but the majority of them just float in the air and rise because the plume exhaled is warm. So if we were to summarize what's happening to particle dynamics, gravitational deposition of larger particles, flow dynamics of smaller particles, and removal by ventilation is the most important removal process. I put in brackets and other processes, but in normal, typical indoor environment, ventilation is the most important. What is the level of our understanding? Very good quantitative understanding based on empirical studies and modeling. No questions about this. Now, typically asked questions, these are usually asked by journalists, but not only. How long will virus-laden particles stay in indoor air? Answer, as long as the forces acting on them will keep them in the air. Minutes? Hours. And how far will virus-laden particles travel in indoor air? As far as the flow will take them. Meters? Tens of meters? Well, possibly also hundreds of meters. So now summarizing this whole area, which I would label as physics of respiratory infections. So there's quantitative evidence on the characteristics of the particles, virus-laden particles from human respiratory activities, a quantitative understanding what happens to the particles in the air, transport and removal dynamics, and also deposition of the particles in the respiratory tract upon inhalation. I didn't talk about these models. So we can ask the question, all right, is this kind of evidence available during each outbreaks? Unfortunately, no, because as you could see, this is a very complex process, and we never have all the required parameters in real life scenarios because there's no researcher collecting this information and data. By the time the outbreak is over, it's like the crime scene, the suspect, the virus left, and we don't know exactly what happened. But there's plenty of evidence from outbreaks for which we use different approaches to quantify what happened. Now, one of the earlier studies in which I was involved and earlier outbreaks which was reported was this one in Skagit Valley, where 53 out of 61 participants got infected. We did do modeling. I'll talk a little bit more about this modeling with colleagues. And this is one of the diagrams from the paper where we show the quanta concentration and the probability of infection as a function of time with this particular assumed emitted quanta. But the bottom line was that the model results agreed very well with the outbreak data. I was also involved in another study which looked at this in a slightly different way and came to the same results. A different way of modeling was conducted on this outbreak, the Diamond Princess cruise. Here, the researchers looked at the different transmission modes and the viral source. So what they showed that for the short range, now they call it droplet and aerosols, compared to long range when where only the smaller particles were present, or fomites, by far the more important was long range smaller particles. Fomites played smaller role, and aerosols, which means smaller particles, contain much higher viral load. A different type of modeling yet was presented in this paper, where the researchers looked into 12 modeled and documented outbreak data, modeled in blue, documented in red. And the assumption in the modeling was that all cases were caused by long-range transmission, which what we call inhalation from the airborne transmission. And what they found was that there was an agreement in 9 cases, which basically demonstrates how significant airborne transmission is, and that we definitely need to mitigate airborne transmission. So I'll talk about this mitigation, but before this, I'll just a reflection. We have all this quantitative evidence about these processes, as I discussed, but this evidence is questioned and not accepted, particularly by the medical community. So why is this? If we accept transport of other objects in the air and its impact, for example, a seed hundreds of meters from a parent tree and how species progress this way, or dust particles thousands of kilometers from a source causing air pollution episode dust storms. So should gravity be questioned? Well, we don't trace the individual seed or the dust grain, but we rely on various models and other evidence to explain what happened. So we accept this kind of evidence and modeling in those cases, however, not in the case of airborne transmission of infections. So what we are saying, well, in similar way, physics-based evidence should be used to explain airborne transmission of respiratory infections. However, medical community is calling normally for randomized controlled trials. Unfortunately, this kind of trials were not designed for environmental epidemiology, but for testing, for example, the efficacy of drugs. Well, how effective is parachute in preventing injury or death? Should we have controlled trials on this? And sure enough, there was a paper published in the British Medical Journal questioning this. So systematic review was conducted. And interestingly enough, the conclusion was that the effectiveness of parachute has not been subjected to rigorous evaluation by using randomized controlled trials. So we don't know. Now, I should add here that this was published in a Christmas edition of the British Medical Journal. I'll come back to this point later. So basically what I'm saying, it's not randomized control trials, but we should use the evidence which we have, and based on this mitigate airborne transmission. I'll be talking here specifically about building engineering controls, and there are quite a number of them: sufficient and effective ventilation, avoiding recirculation, filtration, disinfection. So I'll focus specifically on sufficient and effective ventilation. What is this? Sufficient means enough of it, and effective means everywhere, and also such that airflow is not from one person to another. In this diagram on the top panel is clearly not enough ventilation because particles are everywhere. In the bottom one, it's a bit better, but still that flow is creates a non-uniform distribution. So a few moments about sufficient ventilation. What is sufficient ventilation in relation to infection transmission? Well, of course, there are ventilation guideline standards. Can we use them for controlling infection transmission? Like, for example, those used to control carbon dioxide exhaled by occupants. It's a bit different here. We need to use different approach, and the different approach means we need to use risk assessment models and tools. And the starting point of this is the notion that when talking about infection transmission, we talk about infectious quanta, not the concentration like carbon dioxide, for example, but infectious quanta, which is a dose of infectious airborne particles required to cause infection in 63% of susceptible persons. This is Poisson's distribution. That's the notion how it is. Now, what does it depend on? Emitted quanta depends on location of the pathogen in the respiratory tract, which I've mentioned before in relation to different viruses. Physiology of the respiratory tract, we are all different. Stage of the disease, the virus moves during the course of the disease. Type of respiratory activity, again, I've explained how vocalization results in more emissions, and the virus itself. But despite these complexities, this approach risk of infection transmission has been done, and the model typically used is the steady state Wells-Rayleigh model. Now I just bring this one, the basic equation here, just to put us on the same page in terms of what's involved in this modeling. So first of all, I the number of infectious source cases, which means number of infected people, the number of infectious quanta produced per source, that's quanta what we just talked about, the average respiratory ventilation rate of susceptible person inhaling this, the duration of exposure, this is a critical factor, and the volume of infection-free outdoor air supplied to the room. So this kind of modeling has been done. And for example, some years ago, we've done such modeling with colleagues here in Brisbane in relation to the Prince Charles Hospital lung function laboratory for 2 occupancy times within 45 minutes. And for 3 pathogens, influenza, tuberculosis, and rhinovirus, which have different quanta emitted. So without going into very detail of each curve here, we can very clearly see that infection risk decreases and decreases on a logarithmic scale as the outdoor air exchange rate increases. During this pandemic, this science of modeling and the tools needed for this have expanded very much. There have been lots of people doing this in a much more, I'd say, sophisticated way. So building on this basic equation, but also adding the characteristics of the size distribution of the particles generated from respiratory activities and the respiratory activities themselves, and so on. So with colleagues, we've built this tool, which is Airborne Infection Risk Calculator, which you can find on our website. And we've recently published a paper, or the paper was accepted last week, about ventilation procedures to minimize the airborne transmission of viruses in schools. And actually, I'm very pleased to say this. I'm not going to go into the details of what's on this diagram, but just to say that this approach now is being used by the Italian CDC in terms of guiding the risk assessment process. But as I said, there have been others doing similar modeling, and particularly this good paper published by Bazant and Bush, a guideline to limit indoor airborne transmission of COVID. So again, you see the time here. In this case, they've looked at the masks versus non-mask and different ventilation scenario. Again, I'm not going to discuss the details of this. So summarizing what we know about sufficient ventilation. So addressing the requirement for sufficient ventilation is relatively easy. We can do this. However, one kind of key limitation is that there's an assumption about uniform mixing of the air, which is not always the case, or often not the case. So this brings us to effective ventilation. You might have seen or heard about this outbreak in the restaurant in Guangzhou. So in this part of the restaurant room, there were infections from one infected person sitting here, and air was turned around by the air conditioner sitting here on the wall. So all the infected people were here, no one was infected there. So the point is that, well, there's no doubt that there was a problem with a very low supply of fresh air, but it was this airflow direction was the problem. Well, what we can do to avoid this or to predict the solution? Well, we can, for example, use CFD modeling, computational fluid dynamic modeling. Will it answer all the questions in terms of the desired flow direction? It would for specific indoor spaces, but we can't do CFD modeling for every school, classroom, for every office. So the question is the generalization, how to find general solutions. So in summary of this aspect, effective ventilation, which is based on airflow, this is still a challenge, not that we can't do it, but that we need to do it such that we can come to some generalized solutions. So this brings us to the last part, which is the future beyond COVID-19. And that's what we've tried to explain in this science paper published a month ago. What should happen, and it should be a paradigm shift to combat indoor respiratory infections. Not just COVID, every respiratory infections to which we are subjected all the time. So there are two elements of this paradigm shift. First of all, action, which is the paradigm shift in how buildings are designed, equipped, and operate to minimize all air hazards. And by this, we mean everything which impacts indoor air quality, including airborne infection transmission. And the second element of the paradigm shift is perception. And this is the shift in perception that we cannot afford new ventilation systems. It's been shown in the studies, economic studies conducted, that the impact of indoor air pollution, and again, whether it's infection transmission or, for example, bushfire smoke, which penetrated indoors, by far exceed all other costs. So cost of COVID is estimated at the level of $1 trillion monthly dollars. Cost of other transmission in US, and that was pre-COVID, including influenza and other respiratory infections, around 50 billion annually. For comparison, in Australia, it is annually up to almost $140 million. Every country has such estimates, but it's not doing anything about these estimates in terms of lowering airborne transmissions. So the solutions, as I said, the solutions are here. So it's not that we need to come up with some magic solutions, but to do something using what we know, and as I said, generalize this and then bring this also to the specific situations. So in this simplified image, we are saying what happens. For example, starting from the top diagram, first of all, the interiors have to be designed for the maximum occupancy, and planned for the sufficient ventilation should be planned to include infection transmission. And we have enough data for infection transmission from influenza and other respiratory infections that we can build this in planning. But this should be flexible and demand control. So like in this situation, there are fewer people. We don't need this much ventilation, which means much lower energy consumption. Energy consumption is a very important part of this whole equation. Now, improved air flow distribution. As we can see here, air flows from two different directions, better distribution, and therefore we need less air. On the last panel, we can see personalized ventilation. This is only applicable to the situation when people are stationary, but in this case, there's much less air needed, which means, again, much lower energy consumption needs. So solutions are there, we just need to use them. I will finish with this image from last year's November edition of Scientific American with the question, or statement, the 1918 flu killed millions, then faded from collective memory. Could the same happen with COVID-19? There's absolutely no doubt that it will happen to COVID-19. We will forget it. But we hope, but by we, I mean the scientists working in this field, that the pandemic will influence this paradigm shift in combating indoor respiratory infection. And we compare this, what we hope will happen, and the scale of this to the scale of the Chadwick's sanitary report in 1942. And Sir Edwin Chadwick led the British government to encourage cities to organize clean water supplies and centralized sewage system, which now is everywhere in developed countries, and we have the same with clean air everywhere in our indoor spaces. Now, before I finish, I'll come back to the parachute issue. Well, you would be surprised to hear that, in fact, there was a randomized control trial conducted several years after that first paper. And you'll be even more surprised to find out what was the conclusion. The conclusion was that parachute use did not reduce death or major traumatic injury when jumping from aircraft in the first randomized evaluation of this intervention. How come? This was the design of the study. People were jumping from the stationary parachute. So the devil here is in detail how it is designed. With this, thank you very much for your attention, and I'm looking forward to your questions.
Thank you, Lydia. Now we
Hello.
welcome. It's late afternoon on the East Coast, and I know it's almost 7 o'clock in Brisbane. So Chris, take it away. Thank you for that wonderful lecture.
Lydia, thank you very much. We have a question in the Q&A. I guess I might have to read this out for you. It's from Rob Dearden. Thanks. It was a fascinating talk. In outbreak simulations, do you have data that allows you to differentiate between airborne transmission and fomite transmission from people moving around a lot? Without calibrating data, I can imagine being able to simulate similar looking outbreaks with either high airborne transmission or high person mobility in my model. Did that get, you have all that? I don't have a way
Yeah,
to.
well, this is the biggest question, and the dream of everybody studying outbreaks is to have the kind of data. The problem is that, of course, there were no researchers there, so from retrospection, all this has to be painstakingly reconstructed how it happened. So in terms of, to an extent, we can simulate the situation of ventilation, how it was, what was the setting based on what the setting indoors, the temperature outdoors, the flow of the air, reconstruct where the people were moving, where were sitting. But then the question where we're touching fomites, the only way to know about this is to use the record from video cameras, if there are video cameras. So for example, in the case of that restaurant, the Guangzhou restaurant, the researchers managed to get access to the video cameras and then watch this carefully who was touching, including in particular the waiter. In that case, the waiter potentially was the vector because he carried the plates, and the plates potentially. So in that case, they excluded fomites as a potential of spread. In the Diamond Princess, they've also used all this information, but this is extremely difficult. As I said, it's only based on video camera. This kind of information and data can be obtained.
Thank you. So we have another question from Jeff Morris. I'll read that out. Infectious disease scientists seem to think that aerosolized viruses have very high R naught. For example, measles, which has an R naught of the order of 12 or more. They think the estimated R naught of 2.5 to 4.0 for the SARS virus meant that it must be spreading via aerosol spread. What are your thoughts on this? Is a two-part question. What are your thoughts on this viewpoint, and what would you say to a person who makes this argument?
Well, there were lots and lots of discussion about that R0 of SARS-CoV-2. One very big difference between measles and COVID is that with measles, first of all, it's absolutely obvious who is infected and how it is infected because it's visible. Infection, there are no basically asymptotic people. So it's very easy to account everybody who is infected. And also the infection occurs reasonably fast. I don't remember what is the time between infection and the symptoms. But in SARS-CoV-2, as we know very well, there are many asymptotic people, or even people who are symptotic but were never tested and confirmed. So in fact, that R0 could be much higher and is much higher than what's assessed based only on the identified cases. I'm not sure whether this answered the question.
I'm not seeing any follow-ups here, but I'll add a question of my own that up until your presentation, it clarified the issue of a paradigm shift in terms of ventilation. So in the United States, where I follow the news, as they talk about reopening, I live in California, so we're reopening. I had thought, based on the research in aerosols and so forth, that there would have been much more discussion about ventilation. And I maybe was looking in the wrong places in the newspaper. I never saw anything about ventilation, nothing in the plans from the White House and so forth. And I don't know if that's unique to the United States, or that this paradigm shift is just that big that people don't even consider it, or I don't know. For example, has WHO talked about requirements for ventilation, or what requirements for ventilation should be? Maybe it would start at WHO.
Well, actually, on this topic, WHO issued recommendations that this was in late February or beginning of March. They published a roadmap for ventilation. So, and that's the roadmap for ventilation in the context of COVID. So this is a good document saying what needs to be done. However, in the document, they don't link ventilation with airborne transmission. So it just sounds like in general, ventilation should be improved and so on, but not explicitly saying that because the virus is airborne. However, in the guidelines, in general guidelines about infection prevention, while they state that airborne transmission is one possible mechanism, but they add qualifiers in. So they state close distance, stress close distance, and on the other hand, the poorly ventilated and crowded places, where I often say that's enough that, let's say, there are 3 people in a relatively spacious room, and if ventilation is not sufficient to remove the virus generated for one infected person, this is already a crowded place. So that this is relative. But so it's the WHO which slowly is making progress in these regulations, but in large, there's been very, very little progress, and not only in the United States. In Australia, the word ventilation is not mentioned at all. The reason for this is that it's much more difficult, and I'm talking here about public health regulations by the government. It's much more difficult to mandate ventilation than to mandate, say, people wearing masks. There is much more to do. Immediately the discussion starts about new buildings and old buildings. So we are talking about, well, retrofitting or doing ad hoc, taking ad hoc measures now during the pandemic. Or when we are talking about the new buildings have to be designed differently. And also this is responsibility between different government departments, because say the Department of Health announces that and recommends that ventilation, that airborne transmission is significant and therefore measures should be taken, including ventilation. But it's not the Department of Health which issues standards, building standards, design standards, and so on. So it has to be a cooperation between the at least 2 governments, if not more, for something to happen. Well, it's not easy, as we know very well. So it's an extremely complex issue. Doesn't mean that it can be done.
We have a question from Madeline Bauer, and she says, the ventilation studies and guidelines must take a fair amount of time to complete. How can we and the guidelines keep up with perhaps changing characteristics of the SARS virus with emerging variants, the Delta virus?
Well, the question here would be, with different variants, whether the same amount of ventilation is sufficient for protection. This could be calculated using the risk assessment tools which I've mentioned. The problem is that with the new variants, we don't immediately have this kind of data available. So it only takes some time until we know, and the key parameter here is, and the key uncertainty is the quanta emitted or quanta infectious. So this takes quite a lot of time to acquire this information for SARS-CoV-2. It was from retrospective data when we modeled the outbreaks back and forth, when we got a reasonable idea of the previous variants. With the new variants, again, it will take some time before we have a confidence that what are the quanta, infectious quanta compared to the previous variants. So there is a bit of a problem here.
So, just sort of a very general question. So the vaccines are very effective, and we're happy that they're very effective. And the United States, at least, has gone from a very bad situation to a very much better situation, and so have other countries. Is the availability of vaccines going to sort of diminish, do you think? And you may have to speculate on this, the interest in looking at ventilation sorts of things, or I would sort of think one would need to quantify how big of an effect that improving ventilation would have for governments to decide to do it. But if we have this vaccine and that seems to be working, we'll just put our money on the vaccine.
Well, that appears to have been the thinking for a while, that okay, there will be vaccine, everything will go away. But if you watch the data from the last 2 weeks in countries which were vaccinated and which went to quite low numbers of cases and deaths, like Israel or the UK, you'll see that now there's again an increase in Israel. Apparently there's a discussion about introducing masks again. Now, the argument here could be, well, perhaps it's not because of the new variant, which was confirmed that it is present there, but maybe because it's because people's activity that all rules were relaxed. Could be a bit of both, but it appears that this new variant is perhaps well, more significant than we thought. So saying that okay, vaccine will forget about this would be wrong thinking. And wrong thinking not only in relation to this virus, which well hopefully eventually would disappear, but we are looking at a much broader picture, means on infection, respiratory infection transmission in general. We always have the flus, we always have colds, we always have other respiratory infections. So ventilation is something, appropriate ventilation is something which would lower all these cases forever, for not only during the pandemic. So I wouldn't, when I'm in my thinking, I'm not even sort of putting that much focus on what ventilation will do for COVID, because probably before all these measures will introduced, hopefully COVID will go, but I'm looking much further into the future.
I have one other question. I don't see any other open questions, but you can maybe address sort of my personal sort of neurosis in terms of flying on an airplane. Right now, I don't need to get on an airplane for anything, but given, I'm trying, is masking enough on an airplane? I've seen papers about the airflow studies and jet airplanes and so forth. I'm not in a rush to get on an airplane, especially if people are unmasked. But if there are, would seem just a few people that are unmasked on an airplane could sort of infect everybody else who was masked. This is my idiosyncrasy, but maybe what are your thoughts about airplane travel?
Well, an airplane is a different environment than office or school, because of the environment is small, so the space is small, and people are in very close proximity to each other and for prolonged periods of time. So these are all the ingredients for infection. Well, air ventilation is usually good on the airplanes when everything works properly. Still, the question is the flow direction, and there have been studies showing that there was unidirectional flow from one person towards the other, and infection occurred this way. But even if ventilation is sufficient and effective, there's no direct flow, it still doesn't remove the problem that we are sitting so close to each other. And in that close proximity, even good ventilation will not take care of the virus emitted by an infected person. So masks are a necessity on the plane. Now, whether mask would protect, the question is how masks are worn. So now we are talking about us as individuals. So if I want to protect myself, I'm making sure that I'm wearing mask all the time and that the mask is properly fitted. If you look around at the habits, how people wear masks, you'll see in how many cases these masks are sitting just at the line of the nose, which means all the air is going below them, between the mask and the face, or even completely below the nose. Feet is loose, so on the plane has as good mask as possible, and keep it all the time. That's the recommendation.
We don't have any other open questions at the moment. I don't have any other questions to add to it. I wanted to thank you for your excellent presentation. I appreciate it. And will your slide set be available for after the session?
We will post the video and on our news feed, that's nis.org/news in about 2 days. So, and if your slides are available, Lydia, we'll put those with it.
You don't have my, yeah, you have just the video. I will email you the slides. Yes, I will.
Again, let me add my thanks. We could talk more about the engineering side of ventilation, ultraviolet light and other solutions, but I think that's a long-term infrastructure question.
Wanted to thank you for getting up this early in the morning in Australia.
Yes.
We do appreciate it.
Yes.
My pleasure, and thanks for inviting me.
Thank you very much. And thank you for the audience who is with us. Thank you. Have a good day.
Okay.